So I don't know if you heard me well.
Okay. Good afternoon and welcome to the ESICM webinar. Today you're going to hear from Professor Daniel de Backer, who's head of department at the in Brussels of intensive care, and he's a professor of intensive care at the Université Libre de Bruxelles. Now, I'm sure you know Daniel very well as the past president of the European Society. He's also been instrumental in establishing the EDEC, critical care echocardiography, and as I'm sure you know, and from all his publications, he's a real expert in heart-lung interactions. Now, in terms of COVID, there's been a number of ESICM webinars already, and we heard last time about ventilation of these patients, which presents a number of problems, and we heard about the different possible phenotypes and presentations and solutions for different kinds of ventilation. Now, this is very important for framing this discussion, which is about the heart-lung interactions, which can tell us a lot about the hemodynamics. So the hemodynamics. Hemodynamics is very important in these patients because, as we know, they can become very unstable, and they also get multiple organ dysfunction. So anything we can do to help manage their fluids and other therapies to reduce this end organ damage will be really beneficial. So really this gives a lead into Daniel's talk, and he's going to talk to us for the next hour about heart-lung interactions. For your colleagues who aren't able to see this webinar will appear on the website, and also you'll have the opportunity to pose some questions which I'll put to Daniel at the end. So I'll leave you for the presentation with Daniel.
So thank you, Nick. It's my real pleasure to be here this afternoon and to discuss with you these heart-lung interactions, especially in the context of the COVID. Of course, because the disease is relatively recent, we do not have specific data in this context of COVID, but nevertheless, we can, at this stage, try to interfere from what we know in other types of lung disease like RDS and others, to try to understand what could be the heart-lung interactions in this kind of COVID-19 pneumonia. So the basic principle we need to look at is the fact that indeed the heart is in the chest, and there is also a very specific relationship between the right heart and the left heart because both are joined into the pericardium. And the changes in pleural pressure that will be induced by the mechanical ventilation will be transmitted to the pericardium and hence affect both the left heart and the right heart. One may expect these issues to be really occurring mostly in patients with RDS because these are ventilated with the highest intrathoracic pressures. Nevertheless, one of the factors that may play a role in these conditions is the fact that the transmission of alveolar to pleural pressure is not really straightforward. Indeed, the transmission depends on the lung compliance. And basically, compared to normal, the compliance is, of course, altered in patients with RDS. And hence, for a given alveolar pressure, the pleural pressure or the amount transmitted to the pleural pressure will be somewhat lower in RDS compared to normal conditions. In normal conditions, about 1/3 of the pressure is transmitted to the pleura. However, in RDS, it can be much lower, and sometimes 20 or even lower than 20% can be transmitted to the pleura. So the transmission is really decreased usually in low compliance states, even though higher pressure is applied. And also we need to realize that collapsed areas do not transmit pressure. And of course, in these conditions, we know that The cardiovascular effects of mechanical ventilation are often more prominent in COPD patient or in asthma patient ventilated with high volumes than in RDS patients ventilated with lower volumes, and even though the pressure is higher. However, the COVID is somewhat special because indeed you realize that in many conditions, the condensation is really not the prominent factor. And so what is exactly the transmission of alveolar pressure to pleura in COVID-19 related RDS? So we have already some data showing that we have a very close or initially relatively normal compliance despite markedly elevated shunt fraction. And hence, the transmission of Peep to the pleural pressure may be higher in these cases than in classical RDS patients, at least in the initial states. And if we look at the level of shunt estimated, by the way, by the PF ratio that we have here in these very recent data from the Italian group in the Lombardy region, you can see that the PF ratio is 125, 150 as a median value. But you can also see that the median PEEP is 13 to 14 centimeters of water. So quite elevated pressure that is applied in this condition. And that, of course, will contribute to significant hemodynamic alterations in these conditions. So perhaps the heart-lung interactions will be more present in these patients with COVID-19 than in classical RDS, but we still do not know exactly because we do not have enough data published in this specific subtype of patients. So if we think as a principle of heart-lung interactions, these are quite variable and will be applied on two different ways. On one hand, it will be looking at the repercussions of the mechanical ventilation on the heart and then on cardiac output and on the heart and on the backflow to the CVP and then on the peripheral organs by the increase in venous pressure. And on the other hand, we have also to discuss the response to fluid, which can also be assessed, of course, by the heart-lung interactions. So the principle is that, of course, ventilation will induce cyclic changes in intrathoracic pressure, and that these changes will affect, as again, the left ventricle, the right ventricle, preload and afterload of these ventricles. So during inspiration, there is an increase in the right ventricle afterload. And of course, this may decrease the cardiac output or stroke volume of the right ventricle. The impact of ventilation of the right ventricle afterload is somewhat dependent on the volume of the tidal volume of our patients, and we will discuss this by these relatively old physiologic data. What we know is that we have some alveolar vessels, and we have also extra alveolar vessels. What occurs is during tidal ventilation, there is, of course, an increase in the lung volume during ventilation, and this will squeeze the alveolar vessels and will, on the other hand, distend somewhat the extra alveolar vessels. And so, if we look at the impact on the vascular resistance on the different vessels, for the alveolar vessels, there is a progressive increase in the resistance of these vessels because indeed these vessels will be squeezed during the increase in the tidal volume. On the other hand, for the extra-alveolar vessels, because these will be dilating, on the other hand, there will be a decrease in the resistance of these. So the sum, which is the resistance that the right ventricle is seeing, is like a U-curve with a minimal resistance at the level of the functional residual capacity. The issue is that we ventilate these patients, usually selecting the PEEP to have the best functional residual capacity. And so we'll increase during ventilation the resistance. And of course, the higher the tidal volume, the higher the increase in resistance in this condition. As you can also see, the relationship is not really linear, it's more exponential one, increasing even further with even higher tidal volumes in these conditions. The other part is the fact that there is a decrease in right ventricular preload. And of course, this is just due to the increase in intrathoracic pressure. Both of these effects will decrease the right ventricular stroke volume. This has been nicely illustrated by Antoine Verbaron and his team in that trial a few years ago, when they looked with a transesophageal echo at the dimension of the right ventricle during inspiration and expiration. And what they described is that there is a decrease in the stroke volume here. The diastolic area, the systolic area, and of course the difference here is the stroke volume. You can see that there is a huge decrease in stroke volume during inspiration. And this decrease in stroke volume was due to a combined effect. On one hand, on a decrease in the right ventricular preload, because indeed the diastolic area decreased during the inspiration, but also an increase in the right ventricular afterload on the same hand. So the combined effect here play a role on this decrease in stroke volume. So there is also an effect on the left ventricle, and there is an increase in the left ventricular preload. Why is there an increase on the left ventricular preload? Because there is some squeezing during ventilation of the pulmonary vessels. Indeed, the pulmonary vascular bed is estimated in normal conditions around 400 milliliters. How much is it affected by disease is not well known, but what we can indeed see is that during inspiration, there will be compression of this pulmonary vascular bed, and this amount of blood will be squeezed to the left ventricle, and so increasing the preload of the left ventricle exactly at the same time. And so there is some variation in the left ventricular and right ventricular stroke volume over one respiratory cycle. And this has been very nicely shown by some physiologists from the Netherlands in the early 19th. And this is just one of these measurements showing that indeed the pulmonary blood volume is decreasing during inspiration and increasing again during expiration. At the same time, what you can see, is that we have for the right ventricle a decrease in stroke volume during inspiration and an increase here during expiration. And so, of course, the average cardiac output will be preserved, but this will, of course, be some variation between inspiration and expiration in the stroke volume itself. There is a second factor, of course, for the left ventricle, which is a decrease in the left ventricular afterload. And if we realize schematically, is that to produce some pressure outside the thorax, when we apply no pressure in the thorax, the ventricle needs to generate, of course, the same identical pressure. If we have, on the other hand, we apply some pressure in the thorax, to generate the same pressure, the ventricle needs to generate a lower pressure. And this is just illustrating this decrease in left ventricular afterload that is applied by the intrathoracic pressure during mechanical ventilation. So both of these effects on the left ventricle may, of course, increase the left ventricular stroke volume. We can immediately, of course, realize that the increase in left ventricular stroke volume will be higher in conditions where the patient is preload dependent, because, of course, in this condition, the increase in the left ventricular preload will increase the stroke volume. But even in patients who are not preload responsive, the decrease in afterload may, in some conditions, already increase somewhat the left ventricular stroke volume. Usually will be quite minimal, so we'll see that the heart-lung interactions can be used to really predict the response to fluids. During expiration, there is something different occurring on the left ventricle, because there is the decrease in the left ventricular preload here that will be related to the transmission to the left ventricle of the decreased right ventricular stroke volume, and this occurs after a few cardiac beats. So usually, because we have during the inspiration the decrease in the right ventricular stroke volume, this reach the left ventricle only as the initiation of the expiration. So we see only the decrease in left ventricular stroke volume only during expiration. And this was nicely illustrated in the 60s in an experimental conditions. Here we can see a true measurement of vena cava flow. And we can see that immediately after insufflation, there is a decrease in vena cava flow. And of course, during expiration, there is a return back of the vena cava flow here. When we look at the pulmonary artery flow, we have a decrease in pulmonary artery flow just 1 beat after the inspiration. And this occurs during all the inspiration and returns back to normal during the expiration. For the aortic flow, you can see that initially there is an increase in the aortic flow, but during the early expiration, there is a decrease in the aortic flow. So there is a time lag between the decrease in vena cava flow here and the decrease in aortic flow, which is the transit time through the lung. And this transit time through the lung may be somewhat variable from one patient to another patient, but it usually takes 3 to 4 beats, heartbeats to be transmitted. What is the impact on the right ventricle of mechanical ventilation? And so leading to the development of the acute cor pulmonale. So this is mostly related to the presence of pulmonary hypertension in patients with RDS. And there is a decrease in vascular bed, and especially due to microemboli that occur. And we do not know exactly in COVID-19, but we have seen several patients with macroscopic pulmonary embolism occurring. We have also seen that there is a high increase in D-dimers and this increase in procoagulant state. So it is very likely that these microemboli also occur in COVID-19. There is also reduced lung volume, and this is a little bit more debatable, of course, at least in the early phases of COVID-19. For the mediators, there are a lot of mediators that are released that are increasing the pulmonary artery pressure and may, of course, play a role there. And the very important factor at the end is the hypoxic pulmonary vasoconstriction, which also play a role, of course, in this pulmonary hypertension. So what are the impacts of mechanical ventilation here? During inspiration, there will be the increase in the afterload of the right ventricle, and this will decrease the right ventricle stroke volume. And on the left ventricle, there will be a decrease in preload that will be mostly occurring because the dilation of the right ventricle compresses the left ventricle and decrease the preload in this condition, which is a little bit different from the pure hypovolemic patient. It's also important to realize that the vascular resistance are influenced by the West zones, being maximal in zone 1 and lower in zone 3. To which extent these are affected by the pneumonia in these patients is still something we need to look at because it's interesting to realize that because of the lack of condensation, it is very likely that we may face a lot of zone 1 areas in these patients. What are indeed the implications of the different West zones is that in zone 3, we have the pulmonary artery pressure, which is higher than the pulmonary venous pressure, and both are higher than the alveolar pressure. During inspiration in these conditions, there is an increase in the alveolar pressure and transform zone 3 into zone 2, because indeed, at that time, the pulmonary artery pressure is still, of course, higher than the pulmonary venous pressure, but the alveolar pressure becomes higher than the venous pressure, and hence is increasing the resistance in these conditions. So one may expect that the protective ventilations that we apply in many patients by limiting tidal volume and, of course, limiting driving pressure and plateau pressure may limit the incidence of acute cor pulmonale. But what are exactly the consequences on the right ventricle function? Well, the problem is that the right ventricle is very sensitive to an increase in its afterload. These are data from Brown showing that indeed the right ventricle decreases stroke volume for a minimal increase in the pressure in the pulmonary artery. And the right ventricle cannot adapt to acute changes in its afterload. And unfortunately, it dilates under abnormal condition. And this will have major implications because of the interventricular dependence. If the right ventricle dilates, this will have influence on the left ventricle. Indeed, we have here the dilation of the right ventricle and then the squeezing of the left ventricle that cannot really be filled adequately. And in these conditions, we have a decrease in the left ventricular stroke volume in these conditions. And this is exactly what we see here in this patient. We have here the left ventricle, the left atrium, the right ventricle, the right atrium, and you can see here the distension of the right side cavities. And during each inspiration, we can even see here the interarterial septum really bowing even further to the left side, compressing further the left heart cavities. And so there are several ways to look at it. I will not go into the details. This is more for specialists in echocardiography, but the higher the dilation of the right ventricle, the more severe the condition of the right ventricle. Importantly, and this was again nicely shown by Antoine Verbaron a few years ago, is that the total area of the total volume of the heart is quite similar in patients without acute cor pulmonale and patients with acute cor pulmonale. But the difference is really that the right heart is dilated at the expense of the left heart, so that the total volume is identical, but the left heart is really of minimal size, and hence cardiac output is decreased in these conditions. Another very important aspect is the development of the paradoxical septal movement. What is exactly the paradoxical septal movement? Well, the left heart, when there is an increase in its afterload, will have exactly the same systolic time. However, for the right heart, when there is an increase in the right ventricular afterload by an increase in right ventricular in the pulmonary artery pressure, in these conditions, there is an increase in the systolic time. And the consequence of the increase in the systolic time is that at the end of the systole, when there is significant pulmonary hypertension, the pressure in the right ventricle will be higher than the pressure in the left ventricle. And this will induce a shift in the septum from the left heart, from the right heart to the left side of the heart. So we can see here, this bowing occurring here at the end of the systole, as you can see here. And here again, a very nice example here, where you can see this bowing here occurring exactly at the end of systole. Just because it was a little bit more rapid, just to show here, in diastole, you can see here the left heart here, the aortic valve here. And so look here at the septum here. So we are here in diastole. We begin here the systole with the opening of the aortic valve, early systole here. And we see the septum here quite nicely in the middle. What we see here, just at the end of the systole here, just at the end of the T wave, you can see the flattening of this interventricular septum occurring here, because indeed the pressure is higher on the right side, beginning to compress the right heart on these conditions. And again, close to normal during diastole here. What is the impact of mechanical ventilation? We can see here the pulmonary artery pressure or pulmonary artery flow detected here by echo. And you can see that during expiration here and inspiration here, there is a marked fluctuation in this right ventricular stroke volume. And this is indeed due to the increase in right ventricular pressure during the inspiration of this patient here. This was also nicely demonstrated by invasive measurements in the 80s by François Jardin, who showed that indeed here we have the left ventricular pressure, the right ventricular pressure. They applied elevated Peep in these patients with RDS, from increasing from 0 to 20. And we can see not only we have a decrease in the left ventricular pressure, but also we can see here at the end of the systole, we have the pressure in the right ventricle that is higher than the pressure in the left ventricle, so inducing this paradoxical septal movement. And there are several factors that can indeed lead to the acute cor pulmonale. Some of these include the hypercapnia that is present, and you have seen when you treat many of these patients with COVID-19, we can see that hypercapnia is very frequently occurring in many of these patients when they begin to be ventilated. And also the plateau pressure is also a very important factor leading to this acute cor pulmonale. And the actual incidence in, let's say, normal RDS patients is around 20%. We do not know exactly what is the actual incidence of acute cor pulmonale in patients with COVID-19. This needs still to be evaluated in these patients. What is the impact of volume status on the development of acute cor pulmonale? One may think that perhaps the best solution will be to keep this patient as dry as possible. Maybe this is not exactly the best solution, because indeed, when we give volume, what will be occurring is that we will increase the left atrial pressure. And by increasing the left atrial pressure, we will also modify the pulmonary venous pressure. And interestingly, what you can see here is that when we apply some filling to these patients by giving fluids, we increase the pulmonary venous pressure, and we increase by this way the amount of zone 2 and zone 1 compared to other conditions here. So by increasing this, we will we will decrease the vascular resistance by decreasing zone 1, transforming the zone 1 into zone 2, and transforming also zone 2 into zone 3. So the net results will be that by giving fluids, we may decrease the vascular resistance into the heart. You say this is just perhaps conceptual, but it's not really conceptual. This is a very nice experiment from the group of Bicêtre, Jean-Luc Teboul and Xavier Monet, with Émilie Fougière. And what they did is that they they looked at pulmonary vascular resistance by increasing Peep, and they saw indeed that in these conditions, there is an increase in the pulmonary vascular resistance here. But what they also did at a high Peep, they did a passive leg raising test, so increasing the intrathoracic blood volume by this way. And what they did in there is that they returned the pulmonary vascular resistance to the baseline. So this is really showing that filling of the left atrium adequately may somewhat reduce the pulmonary vascular resistance, and maybe in some conditions also improve the right ventricular function indirectly by these conditions. So what are indeed the impact on the right ventricular function and cardiac output? We need to look at this in particular, of course, in the context of COVID-19, and we do not have a lot of data there at this stage. What are the use of heart-lung interactions to predict the fluid responsiveness? Well, we could do a lot of different things, but the most important and most well described is, of course, the respiratory variations in stroke volume that we can use here in many of these patients there. Then what we do is basically evaluating the preload responsiveness during transient change in preload induced by a respiratory maneuver there. And so what we have basically is a tidal volume induces changes in preload. And when we are on the flat part of the Starling relationship, there is no change in stroke volume. When we are on the steep part, there will be a change here in stroke volume. And this, of course, when we look at these respiratory changes in stroke volume, this will predict or might predict the response to fluids. Here we can see looking at this by echo and showing that indeed during ventilation there is a marked fluctuation in the aortic stroke volume. But this can also be, of course, evaluated by several indirect means, including here the pulse pressure variations as described again by the Bicêtre group a few years ago also. And several studies have shown that pulse pressure variation or stroke volume variations very nicely predicts the response to fluids in many conditions, and that the rock curve area is really nice in these conditions, and that the way that these patients can be categorized as responders and non-responders is really well performed using these heart-lung interaction tests. And both the positive predictive value and the negative predictive values are very good in these conditions. So the problem is that we unfortunately have some limitations, and this, of course, may be even more pronounced in the context of protective mechanical ventilation that we apply in these patients. The first aspect is, of course, the low tidal volume. And we have demonstrated a few years ago that when a low tidal volume lower than 8 milliliters per kilogram is used in these patients, the prediction of the response to fluids is really lost in these conditions. And this is a little bit worrisome because we more and more ventilated our patients with tidal volumes lower than 8 compared to what we did previously. High respiratory rates are also a way to unfortunately lose the predictive value, and here change without changing the I to E ratio here. We change the respiratory rate from 15 to 30, and several patients here already at 30 have no more pulse pressure variations. And of course, these were totally lost at 40. So when we increase the respiratory rate, we may unfortunately also lose the prediction of the response to fluid using this test. And this is perhaps dependent on the heart rate also. And so what we found is that with a heart rate to respiratory rate ratio above 3.6, we have a very good prediction of the response to fluid. Below, we lose it completely. Low driving pressures are also a factor playing a role, and these are some data from some French investigators showing that indeed, when the driving pressure was low, we did not have a very good identification of fluid responders. However, when the driving pressure was quite high, above 20, which is really quite uncommon, fortunately, then, of course, we can predict much better the response to fluids. In unselected patients, it begins to be a little bit less well performing. And again, most of the factors associating with the good response were really having a high tidal volume, having a high driving pressure, having a high compliance, and having also a high heart rate to respiratory rate ratio. So this is, of course, not always observed in our patients with RDS, and especially here in the context of COVID-19 RDS patients. The core pulmonale itself may also be a limiting factor. And this was nicely demonstrated by Yazid Majoub and Michel Slama in Amiens. And what they looked is that the pulse pressure variation was identical in patients responding to fluid and not responding to fluid here. But the important aspect is that in these non-responders, these patients had significant right heart dysfunction as related by the ratio between the right side and left heart size. And so when the right ventricle is dilated, we can have some pulse pressure variations, but these are no more related to the fact that the patient will respond to fluid, but much more to the fact that these patients have acute core pulmonale. And this is, of course, a major limitation, especially in the context of the COVID-19, unfortunately. So can be the tidal volume challenge used to try to detect patients who are ventilated with protective ventilation? Well, this was a hypothesis generated by Sheila Mehatra in Mumbai, and together with Jean-Luc Teboul and Xavier Monet. And what they tested is a transient increase in tidal volume from 6 to 8 to unmask respiratory variations in stroke volume. And so it's a complicated slide, but the most important aspect here is that when we looked at the pulse pressure variations, you can see that when the tidal volume was increased, the pulse pressure variation was increased in responders, but not in non-responders. But for the prediction, it was not just increasing the tidal volume from 6 to 8, but mostly looking at the changes from 6 to 8. And as we can see here, the changes in pulse pressure variation from 6 to 8 were really markedly predicting the response to fluid which was much more the case here than just looking at the individual variables values at a 6 or 8 in these patients. So the dynamic aspect, changing from 6 to 8, is much more relevant from any measurement done at 6 or any measurement done at 8 in these patients. And this is nicely shown here by several cutoffs here, but very good ruptures with this type of analysis here. One of the problems still remains that we still may have an issue by increasing the tidal volume, and that especially when we increase a little bit too much the tidal volume, we may sometimes induce some false positive in some patients, especially as illustrated here. This change in stroke volume here is relatively minimal and probably not valuable in many of these patients. So it still carries a risk of false positive response in non-responders. But the most important aspect for today is that the changes in pulse pressure variation or stroke volume variation would also be more prominent in acute or even chronic cor pulmonale. And especially if we increase the tidal volume, we increase the vascular resistance in the pulmonary artery, and hence we also increase in these conditions the pulse pressure and stroke volume variations. So we need perhaps, before doing this test, have some echo assessment of the right ventricle just to ensure that indeed our patients do not have acute cor pulmonale. Otherwise, these tests cannot really differentiate between stroke volume responders to fluids and, on the other hand, acute cor pulmonale. Is the end expiration test an alternative? Well, this can, of course, by doing some pause here, by an expiration pause, we can see that there could be here an increase in stroke volume detected here by different ways. Here it was mostly the aortic Doppler that was used, and that indeed by some changes here during the pause, it can identify responders to fluid in these conditions. One of the things is that the cutoff of 5% is a little bit minimal, and some way to perhaps have a better prediction is to combine the end inspiratory with end expiratory occlusion, so that we have indeed the effects of both respiratory occlusions, which predicts much better the response to fluid than any individual occlusion here. And especially the cutoff here of 13% is much more easy to detect than a cutoff of 5% or 8% here in the other way around. But the similar restrictions of the context of protective mechanism of ventilation apply to this test, because indeed, when the tidal volume is too low, the changes even during expiration, the occlusion will be relatively minimal. And of course, an acute cor pulmonale will also be improved by the end expiration occlusion. So unfortunately, we still need to do the echo before doing this kind of test, just to ensure that the patient is not on the acute cor pulmonale side. And so the prediction of fluid responsiveness using heart-lung interactions remains difficult in RDS patients because of the specific ventilatory settings that we apply in these patients and the incidence of acute cor pulmonale of at least 20% in many of these patients. And with this, I thank you very much for your attention.
Thank you very much, Daniel. That was a fantastic presentation. And even though you had a mask on, we could hear you very clearly. So thank you for this. We have a few questions coming in, but first of all, I'd just like to ask you something about the different kinds of patients we're seeing. So what me and my colleagues are seeing is the two different kinds of patients that have been identified. So first of all, we have the patient who comes in and maybe initially they have a good compliance. We can ventilate them with a lower PEEP and maybe a higher tidal volume, 8 mils per kilogram. They have a low plateau pressure, and when we have a look at them with an echo, their heart seems relatively preserved and maybe quite hyperdynamic. And then we see the second kind of patient. So the first kind of patient probably is relatively easy to do the tidal volume challenge and look at pulse pressure variation, and we can get some quite good information. Then the second kind of patient, and it may be a progression from the first, is when we start to see the low compliance, the hypercarbia, we're going to really high peeps, high plateaus. And when we do the echo and look at the right ventricle, we start to see right ventricular afterload is increasing. We see a dilatation. And in extreme examples, we see really poor right ventricular function, but with a sort of an underfilled, quite hyperdynamic left ventricle is often what we're seeing. So, I mean, and clearly we've talked about sort of microvascular thrombosis in the pulmonary vasculature. So these patients are clearly a lot more difficult to sort of understand and to investigate for hemodynamics. I wonder what your experience is and whether you have any comments about these two different kinds of patients.
So you're totally right. I mean, these are two different phenotypes. Hopefully they occur, let's say, in two different time presentation also. It's this usual good compliance initially, and possibility to ventilate these patients with a moderate PEEP initially. And these patients also have usually a relatively good cardiac function, even though we have seen patients with a left heart dysfunction quite several times also. But usually these patients have relatively good heart function. And also because of the digestive symptoms like diarrhea and so on, often these patients are hypovolemic initially. We intuitively try to limit the amount of fluids in these patients, but nevertheless, these patients are probably the patients who may benefit from some optimization globally of their fluids volume status. I don't say that we need to give a lot of fluids to these patients. This is not exactly what I mean, but we need perhaps to be careful when you give fluids. And fortunately, it is in these patients that the heart-lung interactions will work better than in the other one. In this second pattern, as you mentioned, first, these patients have a very low compliance. We use a high PEEPs. They have a high plateau pressures. They have also often acute corpulmonary due to different factors, including the ventilator settings on one hand, hypercapnia on the other hand also. And of course, these patients may not tolerate fluids very much. So I think that it's good to try to have an identification of these patients, not only by looking at the ventilatory aspects on one hand, but also to perform echo to ensure that in the conditions, especially in second-hand conditions, that in these patients we do not face acute corpulmonary, because the management may be a little bit different in these conditions.
Yeah, thank you. Yes, I mean, it's what we're all saying, and it's certainly what my colleagues have been discussing. We have found echo to be really, really useful in these patients. The windows aren't always great. So there's a possibility for TE. But where we get some nice images, it's really crucial. And the right ventricle is the key thing to be able to visualize here, I think. And this is what one of the questions we have is, how do you suggest to monitor the impact of mechanical ventilation on the RV? So this is where echo really comes into its own. I mean, we've been trying to promote echo and develop critical care echo for years, along with Antoine and a number of others. And I think now is where we're really seeing the benefit of that, with people able to do echo and machines available. I think other investigations, for example, pulmonary artery catheter are useful, and they can show you quite nicely the right ventricular stroke volume, particularly the newer catheters where you can get a real-time stroke volume. But the only problem is where we're so stretched on intensive care to have the time to put the pulmonary artery catheters in, for our doctors to have the time to get the information is not quite so easy. So we're finding echo much more useful at this point. Yes,
but we need to pay attention to contamination aspects, and this perhaps is the most important limitation for widespread echo at this stage, is really the fact that approaching to these patients is always a little bit more tricky because of the risk of a contamination of the healthcare personnel in these conditions.
Yeah, no, we have dirty machines now, so we we managed to order a lot of echo machines, my colleagues. So there's another question now. How many patients will have this phenotype of acute cor pulmonale? And the question is, can we identify these patients by poor response to recruitment or higher than expected dynamic compliance in the ventilator? And if we identify the acute cor pulmonale, should we treat it? Any thoughts on that one, Daniel?
Well, there are several questions there.
Yeah.
And so the most important is how to suspect it. And the problem is that we really have many of the factors that the usual suspects that are present in these patients. As you mentioned, the high plateau pressure, the hypercapnia or acidosis are factors associated with the development of acute cor pulmonale. Infection of the chest and the lung infection is also one factor. And so, by the way, most of the factors there are present in these patients, at least, as we mentioned, in the second phase of the COVID-19 RDS disease. Many patients are potentially affected. We do not know exactly the incidence in this specific COVID-19 pneumonia compared to usual RDS. Is it close to the 20% as usual? Is it higher? Is it lower? We do not know exactly. We do not have this kind of series of echo to help us at this stage, unfortunately. The question on do we matter of having acute cor pulmonale, yes or not? I think it's quite important aspect. Of course, what we want on one hand is to protect the heart, to protect the lungs, sorry. But on the other hand, if we have this right heart dysfunction, which is associated at some point with some decreased cardiac output, but also some increase in the venous pressure and venous stasis, all these factors may have really major implications in our patients. So the way we perhaps adjust the ventilatory settings may be somewhat important there. And at least in our center, it is one of the components that we take in our minds when we discuss either ECMO or in some of the other patients, the ECHO, the CO2 removal in some of these patients. Because CO2 removal can be sometimes interesting to decrease the severity of the ventilator conditions while preserving the CO2 levels, the PCO2 levels, and preventing severe hypercapnia in some of these patients. So this is a way that we can approach this. Whether it will be improving outcome or not, we do not know yet, but it sounds logical to try to limit both this strain on from mechanical ventilation on the lungs, but also the strain of mechanical ventilation on the heart on the other way.
Yes, and it's difficult sometimes to know what to do with these patients. I think there was a patient the other day who had a sort of moderately dilated right heart, and they had an unreactive IVC when I looked at them with echo, but a very small and dynamic left ventricle. So, and interestingly, they had a very high cardiac output, which is around 8-9 liters a minute. So it's difficult to know what to do with these. Clearly, that patient was moving towards a sort of cor pulmonale. The cardiac output was adequate, but they were also developed renal failure. So maybe the cardiac output wasn't actually adequate. So you have to be very careful with the fluids. Now, the other solutions that are being considered, obviously, for acute cor pulmonale are the use of nitric oxide, not available universally and sometimes difficult to use, but it's an option. You could try a drug like Milrinone, but this has a problem with causing hypotension also. So this can be a problem because we're seeing a lot of patients who are quite hypotensive. We've looked at sildenafil, which we haven't actually used, which is a potential NG. This obviously has a problem if you have some liver dysfunction. And the other option is also prostacyclin, which can also cause hypotension. So there's a number of solutions. I think potentially you have to tailor them to the individual, but be really careful about the unwanted effects of these treatments. So there's another question about acute corpinale. Question here: should we still be targeting a PEEP of more than 15 millimeters of mercury, given a high driving pressure, hypoxemia, maybe due to perfusion dysregulation? Any thoughts on that?
Sorry. So I think that the high PEEP or low PEEP is really a very difficult question, because it's such an individual response of the patients that I don't like to say high PEEP, low PEEP. I think that we should discuss more the best PEEP for that specific patient. And the best PEEP for that specific patient is taking into account both its lung properties, including compliance and the response to a PEEP titration, and also the response part in these conditions. Just dysfunction of the right ventricle should not prevent increasing somewhat the PEEP that can still be tolerated, especially if there is some recruitment. Recruitability of a patient with COVID-19 is not that obvious, but nevertheless, response to PEEP is often relatively good in many of these patients in terms of oxygenation and sometimes even in improvement or stabilization of these of the compliance. But the tolerance of the right ventricle is really very difficult to predict from what we see even with the echo. Unless you have really the acute cor pulmonale, whereas with the paradoxical septal movement, these patients will not tolerate any increase in the right ventricular afterload. However, if I can say like this, have some right ventricular dysfunction with some moderate dilation of the right ventricle, then some of these patients may still respond to PEEP in a favorable way. So it's always a balance. And so just as we do the FLETCHER challenge, which is challenging the system, measuring the response, we should also do this PEEP challenge, which is indeed challenging our patients by increasing the PEEP, looking at the respiratory mechanics on one hand, but also looking at the hemodynamic, including the echo, I think, on the other hand.
Yeah, I think that's a really nice concept, the PEEP challenge, because, I mean, as you say, that the right ventricle will tolerate preload quite well, but not afterload. And we don't always know this and where these patients are until we try changing the PEEP. Some tolerate it and some don't tolerate it well. The question here is, this is all fascinating, but shouldn't we keep the patient in the fluid responder group to avoid fluid overload? Yeah, that's a very nice question. I mean, what we should also remember, sometimes we've found these patients are actually really quite hypovolemic due to high temperatures. So also you have to remember, if they don't respond, it's sometimes because maybe you haven't given enough fluid. Maurizio was always very keen on the concept is that the non-responders, you may just not have given enough. So so that's always something to bear in mind as well. Comments on that, Daniel?
Well, I think, yes. I mean, on one hand, if the patient is really perfect, relatively dry, this can be satisfactory. The problem is that it is not always the case. And some of these patients arrive in the hospital with some significant renal dysfunction. And many of these patients is related to the fact that they had high temperatures, sweating a lot, diarrhea, which is also a very common aspect. They're also so tired, and so they do not have really, they do not want to drink, or they do not eat anything. And so they are, some of these patients are really dehydrated initially. And when you put these patients under mechanical ventilation, you even further impair the hemodynamics of these patients. So giving some norepinephrine to preserve blood pressure is okay when you just have vasodilation, But when you have a severe hypovolemia on top of this, it's probably not the best solution. So we need to avoid severe hypovolemia. We need to prevent giving too much fluids to these patients also on the other hand.
Yeah, thank you. So, question, what has your fluid strategy been for these patients, being they seem to evolve from one phenotype to another? I think we've tried to answer that question. You have to challenge these patients really to know, and I think it's important to institute hemodynamic monitoring early, and also to understand carefully where the patient is in terms of these different disease patterns that we've recognized. Other question, are you using TE routinely, and how are you cleaning the probes? We're not using TE routinely. We use it if we really have to, and then we try not to tell the cardiologist about what we've done with the probes. You can get quite good windows, and I would encourage, if you don't get the normal windows, have a look at the subcostal, because you can get some really nice subcostal images, often with the high PEEP. The heart's just displaced a bit inferiorly, and you can get nice subcostal long and short axis, which will give you a good, possibly the best picture of the right ventricle, and also obviously the IVC. I'm just going down. What else have we got? What maneuvers would you recommend to find optimal PEEP with monitoring right ventricular function? So I think we've discussed that one. There was a question about proning. It's not necessarily related to the hemodynamics, but obviously people have got a lot of questions about all aspects of management. Given all the interactions mentioned, should the patient go prone in order to improve gas exchange before reaching high PEEP pressures? It's difficult to know the effect of being prone on hemodynamics, but
yeah.
Any comments?
Well, I will not comment too much on the ideal timing of proning. I think that we base most of our discussion on PF ratio based on the Guérin trial and other trials, but when we decide to prone, it's really something very important that we have some improvement often in the hemodynamics also of these patients. And most of the effect is probably driven by the improvement in the right ventricular functions that we observed. This was nicely demonstrated a few years ago by the group of Antoine Baron again, by performing TE before and just after, and confirmed by some other French group doing even TE during proning, that the right ventricle is offloaded during prone position by several factors, and that at the end, the right ventricular function is really markedly improved by proning our patients. So one way to really improve both the ventilatory conditions on one hand and protecting the lungs on one hand and protecting the heart is indeed using prone in many of these patients.
Yes, and I think a lot of the questions are really on these themes of treating acute cor pulmonale and how we titrate PEEP. So it's quite clear that people are all encountering the same issues. And I think the idea of the volume challenge and also the PEEP challenge, which both tell you about volume and both tell you about ventilation, I think are very useful in this context. There's quite a few people asking about different therapies we use. For example, inhaled Milrinone. I haven't got any really experience with inhaled Milrinone in these patients. I think it could potentially avoid the systemic effects of hypotension you can get with Milrinone. So I think it's maybe worth a try. Obviously, one has to be a little bit careful about aerosols and using sort of inhaled things like that. So it could be problematic from that point of view. We've talked a little bit about right ventricular echo parameters. Certainly, we look at the septal position. You need to look at things like TAPSE. You need to actually just measure the right ventricle and also measure the right ventricle, look at the relative diameter or area compared with the left ventricle, and the sort of standard measures of in critical care echo that we use.
For Nick, for this aspect, I think that for a little bit more advanced people, looking at the pulmonary artery flow is very important, because when you look at this variability and also sometimes the morphology of the aortic of the pulmonary artery flow is very important, because the pulmonary artery flow, when there is some significant variability there, this means that the ventricle coupling with the arterial pressure is really not very good. And so we have a ventricular arterial decoupling when we have this kind of fluctuation in pulmonary artery flow that we can detect by echo relatively easily.
Okay, thank you. Listen, it's now, well, it's 4 o'clock here, so we have to draw this to conclusion, because I know Daniel has to go and I have to actually video into another meeting. So we've had so many questions. We very much appreciate your attention and your questions. We could, I think, carry on for another hour and discuss this subject, but I hope that, and I know that Antoine is doing an echo webinar about COVID patients. So I think that's very much one to tune into too. I think this will go up on the website, the ESSECON website, in time, so you can recommend it to your colleagues. So it just remains to say thank you very much for ESSECON for organising this. Thank you very much to Daniel for the excellent presentation, and we really wish everyone the best of luck, and try and stay safe and stay healthy whilst treating all your patients in critical care. Thank you very much.
Thank you, and keep safe.